with me, it seems as though these people only have a hard time fighting off what they're exposed to, the common day, the cold, the stomach flu, whatever. They tend to be actually healthier than the average person and come down with less of these unless they are on immunosuppressants, which makes me believe that the problem is actually one of recognition of the immune system rather than let's shut that thing down. Has any research ever been done on that?
Connie, do you want to restate the question briefly and provide an answer?
So we should hire you. Because you're nailing this down to exactly the question that has driven immunology for about 50 years. Is there a wrong immune response and then there is a right immune response? And I can tell you after about 50 years of studying this, we've come to the conclusion that whatever the immune system does, it does when it fights the pathogen, and it does the same thing essentially when it causes disease. So we have not been able to take the immune system apart into a red and a green part and beat down one and leave the other intact. And Phil, related to that, that's our dilemma, that whenever we go in and we immunosuppress, we always take away the ability to defend yourself. That's a price we pay. We rather not pay that price, but right now we're not capable of not paying that price.
Other questions in the back?
With MPA, is ANCA, the ANCA test the only way to tell if you're in remission, or what are other ways to tell if you're in full remission?
Okay, so the question, I'm going to just attack and then have Luis Felipe make a comment as well, is how do you know when you're in remission? I'll take the first part of your question, which is in terms of the ANCA. So I think you're going to find at this year's symposium almost universal agreement from the speakers that there is now good data to say that ANCA titers are not something you should use to judge your disease, and you should not be treated based on ANCA titers. It is a wonderful test for diagnosis, and it has changed how we look at the diseases for which it is useful, which includes Wegener's microscopic polyangiitis and Churg-Strauss. You can still have vasculitis without it, for sure, but we thought in the past that it might be useful to follow the titers, and if they go up and down, that means you're getting sick or not sick. There are increasingly good studies and data that based on how we test ANCA now, that is simply not true, and that is not reliable enough to use to base fairly toxic therapies on. That may change with better testing, with different types of ANCA testing, and with better data. But for now, the vast majority of experts in vasculitis do not treat based on the ANCA titer. And that may be different from what you're getting at home, and I'm not going to get into the individual. The second part of your question is, what do you use to determine if you have active disease or not? And Flores-Suarez, can you talk to us briefly about that?
Yes, what you need is first to see the patient, to explore him, to question him, and then to know if he has some complaints that you can thereafter attribute to disease. And that's something we shouldn't forget. So it's a combination of items. The physical examination, the questionnaire, and also some other tests that may be available. And specifically depending on how you know your patient and how he behaves in terms of when he's getting active. So for example, if you have eye symptoms which are dominant, then you should need also the consultation of the specialist. And that is how you build this judgment and conclude if the patient is active or not. So it's not limited to just one test. It's not, for example, as in diabetes. You have high glucose levels, you're out of control. This is not the way it works so far in vasculitis. You really need to summarize many information concerning imaging, laboratory, and also the clinical aspects of the disease to know if you're active or not.
That's a great summary of that. Two more questions, and then we're going to end over there, ma'am, in red.
There are so many different kinds of vasculitis. How much importance is there to have the specific diagnosis? I know of numerous patients who have been just told, you've got vasculitis, so what?
Well, I don't think the so what part's so good. So the question is, do we need to actually have do the names of the individual forms of vasculitis matter? They do matter. They matter because we know that the natural history, the manifestations, what happens to the patient differ. So how you follow the patient makes a difference. What you concentrate on, what you think could be their vasculitis or not. And importantly, the treatments are different. Sometimes the treatments may appear to be subtly different, but sometimes they're very different. And what happens down the line, whether we keep people on therapy or not. So knowing exactly what your diagnosis is important. Sometimes you don't know. It's SSV, some sort of vasculitis, because you haven't had a particular manifestation that says, oh, I know it's that. But to the extent that you can narrow it down, it is very useful. Our research is focused on the names. On the other hand, we get a little hung up on the names, and it may prevent us from seeing the broader picture. And the names sort of change over time. But having a specific diagnosis, you can, as long as it's correct, is fine. Sometimes patients have something that pops up later, and they say, well, maybe that wasn't what you had. You have something else. And then one more question. Caitlin.
To avoid overtreatment, when you decide that the patient, if they've been in like a good time for a while, can change to a less, or patients that constantly flare, do you just kind of stick with what works?
Okay, so that's like the hardest question in the world. So the questions, so I'll ask Phil. So the questions are, how do you know when to stop, and therapy when it had enough, and are there people that you should just keep treating? And you don't have to answer for every vascularity, but you might want to generalize it.
I was going to point out that the person who selected the question should probably try to take a crack at this. Let me say...
I was just playing favorites. She's my patient.
No, because I remember you came 2 years ago.
Sorry.
No, that's okay. Let me say this, though, especially you at your youthful age. You deserve a chance at some point in your life to come off the drug. And even though we don't know who needs to be treated for how long, eventually at some point someone will probably just stop the drug just to see what happens.
But then
We
we're
know,
back.
we know from other diagnoses, for example, Weber's granulomatosis, which I know you don't have, but it's a good example, that a small number of people, like 25%, will actually go into very long-term remission even without drugs. And because you might be one of those people, you deserve a chance to find that out. I will say that the odds are against you, and if you do flare, then that's probably a reason for you to go on longer courses of immunosuppression, thinking that in general the drug is probably going to be safer than you suffering another severe flare.
So I think it's actually a happy question, because in a way we're saying, okay, you're doing well for a long time, when can you stop the drug, as opposed to you're doing poorly, what's the next agent? So if we get to these research questions, which are being addressed in research studies, is when can you stop? That is progress, and that's what we're talking about. I'm going to end. It's time for dinner, and then we're back at 7 o'clock, and then we'll have some, in about half an hour after that, they'll be starting the program again. The 7 o'clock is for dessert, so leave room for dessert from dinner. Okay, thank you.